Welcome to Unit 2 of this module on follow-up and monitoring. In this unit, we will look at aspects of monitoring, including monitoring parameters, process measures, and indicators. By the end of this unit, you will be able to describe relevant monitoring parameters, process measures, and indicators. It is important to know whether antenatal services are performing well, providing respectful services according to SOC recommendations, and what effect this is having on STI, RTI rates among pregnant women and their newborns. In this unit, we introduce a few simple approaches to monitoring that can help answer these questions. Both are based on routine reporting, or the information reported by clinicians about their patient visits. We also look at how national programs can monitor antimicrobial resistance patterns and trends. Important examples of program monitoring include screening pregnant women at their first antenatal clinic visit or monitoring gonorrhea infection rates, which is important for AMR. This can be easily done and updated on a monthly basis, with a few pieces of data routinely collected by clinicians. For example, look at this monitoring method using syphilis screening data for 1 year. The overall denominator is the estimated number of pregnancies since all pregnant women are expected to attend ANC, for example, 430,000. All women attending ANC should be screened, so we use the number of pregnant women attending ANC during the year as the denominator. Example, 420,000, ANC attendance is 98%. The number of women screened for syphilis, not the number of screening tests, which may include duplicates, is the numerator. For example, 400,000. The overall ratio is 400,000 over 430,000, which is equal to 93% of pregnant women screened, or 400,000 over 420,000, which is equal to 95% of ANC attendees screened. This STI screening information can be presented as part of a cascade analysis. Other important indicators shown here are syphilis positivity rate and percent treated. The first chart shows ANC screening performance. The second chart indicates the positivity rate among those tested. To calculate this, the number of women screened for syphilis from panel 1 is the denominator, for example, 400,000. The number of women screened who tested positive is the numerator, for example, 80. The ratio is 80 over 400,000, or 0.02%. Finally, the third chart shows the percentage of those positive who were treated. To calculate this, the number of women who tested positive is the denominator, for example, 80. The number of women with a positive test result who received effective treatment, for example, 77, is the numerator. The ratio is 77 over 80, or 96%. The number of women with syphilis whose partner is treated is calculated in the same way. Program data can be analyzed and plotted monthly, providing timely information about program performance and helping to identify problems. It is also important to monitor STI trends in this way to see whether things are improving or not. For example, this graph shows syphilis and gonorrhea trends in Sri Lanka, including recent trends in pregnancy. There are 2 levels of monitoring related to AMR, measuring process, describing practice, and outcomes, AMR patterns and trends. They are AMR process indicators and AMR outcome indicators. AMR process indicators should be monitored to some extent at all healthcare facilities. Information from routine medical records, including charts, prescriptions, etc., are tracked to document key treatment details such as agent, dosing, administration route, clinical indication, and duration. Planning for how to organize this is an important step for national antimicrobial stewardship programs. Monitoring of outcome indicators requires a higher level of laboratory capacity and is usually done at district, regional, and/or central levels. AMR patterns for gonorrhea are essential to inform treatment guidelines and can be monitored at clinical sites that have capacity to perform culture and antimicrobial sensitivity studies. The main outcome indicator is the proportion of gonorrhea isolates resistant to commonly used antibiotics. To calculate this, the numerator is the number of gonorrhea isolates resistant by antibiotic. The denominator is the number of gonorrhea isolates tested with each antibiotic. Practitioners should also be aware of the WHO Gonococcal Antimicrobial Surveillance Program, or WHO GASP, that specifically focuses on monitoring global gonococcal AMR patterns. WHO GASP is a collaborative global network of regional and sub-regional reference laboratories. It was initiated in 1990 to monitor gonococcal AMR worldwide. Countries that participate in this network have access to epidemiologic data that helps ensure adequate AMR surveillance in order to inform national treatment guidelines, establish a strategy to rapidly detect patients with gonococcal infections who experience a clinical and/or microbiological treatment failure following treatment with recommended cephalosporin therapy, and ensure the effective clinical management of infected patients and their sexual partners. Of note, GASP protocols call for measuring AMR in men with urethral discharge, not in pregnant women. Monitoring AMR in pregnant women is not recommended because the yield is higher for men, and it would take a huge amount of gonococcal cultures in women to isolate the required sample size for gonococcus in antimicrobial susceptibility testing. You can get more information on WHO GASP in the recommended resources for this module. To summarize, monitoring program indicators include screening performance against targets and prescribing practice. Monitoring STI-RTI trends overall and among pregnant women and newborns is important to know whether programs are effective. Monitoring AMR trends can be done at healthcare facilities that perform gonorrhea culture and data used to guide treatment recommendations. You've now completed Unit 2, Monitoring STIs, RTIs, and AMR in Pregnancy. We will now look at the topics we have covered in context using 2 case studies.